Okay, well, if I'm too loud, just let me know. So we were asked by, under this, one of our projects that we're funded for, to do a survey on MAT. And so this was under the project, so the Opioid Learning Institute is a program that we run at HealthHIV, and we do a lot of different work with e-learning, resources, training, a lot of, sorry, as you know, the naloxone kits and the naloxone training. So we work with DC Health to expedite a lot of those processes and bring the training out to the community and help provide them, outreach workers, with the resources that they need within that. So yeah, this is just kind of an explanation of like a lot of what we do, really kind of the webinars, the CEs, so reaching clinical and non-clinical providers. So all of those that really work in this space, we try to touch them and give them the resources that they need and work with the health departments to make sure that we're reaching the populations that we need to. So they asked us to create a community of practice survey on medication-assisted treatment. And so the goal was really to increase MAT prescribers and improve integrated team-based services for individuals with opioid use disorders. And so really understanding who's doing this, what are their challenges, what are some of the things that we can help move them along, and what do they need within that. But we also want to understand, one of the things that we know that we've talked a lot about with this conference is that there's stigma that's associated with the work that we do, and stigma is also present in providers as well. So really understanding where they're coming from so that we can address their perspectives and try to eliminate some of that to make sure that there aren't barriers such as stigma when people are accessing these services, and understanding what kind of technical assistance providers need as well to do this. So we worked with DBH and HOSTA to develop the survey collaboratively. We developed it in REDCap, so I'm not sure if either of you have used that, but it is a great resource. It's free. It's Vanderbilt has created it, so you just have to apply to have an instance of it, and so we did it within that. We did it last August to September, and we did 8 recruitment emails, and we got 120 participants within the survey. So here were the survey participants that provided MAT services, so our MAT services, and so we're across the district. We also got some, in Maryland as well as Virginia as well. So this basically shows we have a good representation geographically from this. This I made in Tableau, so Tableau is a great visualization tool. Unfortunately, they don't do geography by wards, and I know that's how everybody speaks here. That is a recommendation I've made to Tableau, but this is what we have right now. But we really do see, if you kind of overlay the wards and you look at the opioid crisis as well, the providers that are answering it are really working within those wards that are disproportionately affected. And sorry, if you guys have any questions or thoughts, I hope it's obvious that you can just interject. No hand raising is needed or anything like that. So, great. So who participated in the survey? Hey, come on down. We're a family here. Oh, you forgot your jacket. That's why. Jeez.
You're real excited there.
I know. It's like you're at the school of dance, and you think somebody's coming up to you to dance, and they're going to someone in behind. Oh, you're here. Okay. All right. There you go. You're dancing with me. All right. Perfect. So, who was involved with this? We had 37% were social workers, then we had about 22% nurses. We did have physicians, mid-level providers, so prescribing providers about 14%, as well as pharmacists, and then 22% identified as other, so those were admin positions, executive positions, and dental workforce within that. And then we asked them what their specialty was, and so mainly it came from mental health or psychiatry. There was 8% from emergency medicine, 13% from family medicine, and 13% general practice. So those were the top within there. And then practice setting, 20% from the health department. So when you team up with the health department, you often get a larger response rate from them as well. But we did get good representation from private practices, and that's often, in private practices, we often don't know what goes on there because you're usually not as connected as like the FQs and the FQ lookalikes. So we were happy with that representation. And then substance use facility, which is really important, and then FQ and FQ lookalikes. Great. So welcome, newcomers. We're really informal here, so we're just trying to get to know each other. My name's Erin. I'm from HealthHIV, and we're just talking about a survey that we administered looking at MAT services in the district and what works and what doesn't work. And so my hope is, now that we have more than 2 people, go us, is that we just present the survey findings, but that we have a discussion together about what do we do next and how do we work together and how do we address what some of these challenges are as well. So we asked if you provide MAT services, and 19% of those who responded did provide their services. And then the majority of those, as you can see from the graph over here, has been administering for about 1 to 4 years. So the people that are prescribing are fairly new at providing MAT services, which isn't overly surprising since we haven't been doing this for like 60 plus years in most cases. So looking at prescribing practices by years of experience. So I'm sorry, but you can't see that, but we do have this broken up. This is buprenorphine, naltrexone, and methadone. And so we asked providers based on years of experience what they have. And so really, there's a lot of colors on here, but like when you look at this, you see that most providers, and again, we only had 19% of the population do it, but are prescribing buprenorphine much more so than naltrexone, methadone. And so that is something that actually, when we go through the rest of the data, that's kind of a theme that keeps coming up, and that's something that we can also talk about of why this might be occurring as well. And also, just for those of you who came in, if you have questions, thoughts, just please shout them out. No needs to raise hands or anything. We're having a discussion here as much as possible. So we asked, what other risk mitigation strategies do you employ? So what else do you do in connection with providing MAT services? And so, 32% do some kind of counseling or cognitive behavioral therapy, right? And so we know how important that is. Just prescribing MAT without any type of support doesn't really have success in the way that we want it. Also doing urine drug screening, looking at opioid treatment agreements as well, so kind of making sure of managing expectations on both sides, and then looking at your treatment goals. What is your goals moving forward? And then prescribing naloxone, getting involved with a state practitioner, PDMP, and then non-pharmacological therapies as well, so like acupuncture and things like that too. So that's what other people are doing in connection with providing MAT services. Do any of you here provide MAT services? Great. What do you all offer? Okay. Oh, sorry. And we have to use the. Wait, do we have a microphone? Sorry. Okay, because we're recording. That's why.
Thank you. We provide assessment, treatment planning, urinalysis, counseling groups, individual counseling, medication management. What else do we do?
Yeah, great. What about others? Does anyone else want to share?
Urine drug screening, medication management. They have peer support. They do groups, and it seems like I'm missing something else. I'm not really sure because I'm not the actual provider. I work in the social service end of it, kind of more so, like doing the gifters and stuff like that and meeting them with social workers. But I'm not really sure if they're, because what's interesting to me up there is the treatment agreement and the treatment goals, which I think is a pretty good thing. And they could very well be doing that with the provider.
Right. And why is that interesting to you?
Because I used to work in treatment before, and I understand that a lot of times you have to bring the patient along with you in trying to help them in dealing with substance abuse. And I think it brings the patient, more into trying to work along with you, and you can kind of get their mindset when you begin to discuss these things. And I think that they should have goals, towards trying to, get better as it relates to substance abuse. So that's why I'm going to go back and ask because I'm curious now, which they might do it.
Great. No, I agree completely with you. I think it's a very empowering strategy, and it makes our relationship way less paternalistic, but more of a partnership and a collaboration that we're in this together, but that you have ownership and autonomy of your treatment in ways you probably haven't felt before. I see a lot of head nodding back there. Do you all want to?
The counseling portion.
Okay.
Yeah.
Great. Okay. Perfect. We'll keep moving then. And so then we were asking about the age of the patients that you treat as well. So the age is fairly distributed, as you can see. The opioid crisis really has no boundaries with class, age, race, gender identity, right? It's all been touched in one way or another, and this is another data point that also points to that. But one of the things that we noticed is that none of the participants reported that they prescribed to patients under the age of 18 as well. So I guess my question to you, and maybe to you, if you had a patient under 18, would you treat them, or would you know where to send them, or is that a big gap that we need to address?
It's not a gap that needs to be addressed, but we can go to the belt. I had to think about. I really have to go into Access Helpline to determine where to send someone under 18. In our program, we don't treat folks under 18.
Right.
And if you pulled a gun on me and made me, I would be able to tell you right now exactly where I would send.
Well, I have no guns, just questions.
I'm just saying that's a heck of a question.
Well, you are welcome. Sorry, would you like to talk as well?
I have a comment. So specifically with methadone and buprenorphine, which are the two more effective treatments, there's a ton of FDA restrictions on prescribing to people under 18. Right. I'm not sure methadone is approved at all, but don't quote me on that. And buprenorphine, in order to prescribe to someone, I don't think it's approved for anyone under 16. And for individuals under 16 to 17, they need to have had at least 2 documented attempts at withdrawal management. So there are a handful of providers in DC who will work with that, but there's just so much more red tape from the federal level to be able to give those medications to a minor than there is to an adult.
Right. And we already know there's already a lot of barriers for adults, and then you put all of that in consent and FDA approval within that, but we know obviously opioid use does not see age, right, within it. It doesn't start at 18. So kind of thinking through, not trying to hit individual providers below the belt, but is that something that needs to be done more, Dan, on a policy level to rectify that as well? Or just to ease barriers within it and understanding and knowing where to send people for that too. Great. All right, so as you remember, in this sample, we had 19% identified as prescribing providers. And to treat MAT services, there's a host of different support services that we need to offer, right? And we went through some of those before, but we also, and that is one of the reasons why we included non-prescribers, because we want to really think of this as like this one door approach towards MAT services, and what are all the touch points that a client may be interacting with as well. So 29% of those who do not provide MAT services directly refer 1 to 2 patients per year, and 48% did not refer any patients within there. So it's people that, you know, are more in the 1 to 10 range, and I think it's, you know, really speaking to, again, having those warm handoffs. I don't do this directly, but knowing who does. And I know that SAMHSA has a lot of tools, as does OLI, looking up prescribers that do that, but making sure that these non-prescribers know who to talk to within to get someone into MAT services, because as we all know, when someone is ready, that is a short window that we have to move someone forward, right? So really trying to capitalize on that, but making sure that we have the resources and the connections to move that client forward if they are ready. Okay, so this is, I'd like to talk to you all about this and get your feedback as well. So we asked participants about effectiveness and knowledge related to different MAT medications or strategies. And we asked about, so how about this? When you see this, what does this say to you? And there are no wrong answers, for real. But like when you say this, what pops out to you? So 67% thought buprenorphine was effective, 54% methadone, naltrexone 51%. And then, but look at, so all these people that participated were providers in one way or another that wanted to complete an MAT survey, right? So these weren't just like a national survey. These were all in the DMV that wanted to complete the survey. But of those, so meaning there's some selection bias within that, but within those, 21% did not know the effectiveness, okay, of buprenorphine. 34% didn't know methadone, and 20% of naltrexone. And these are people that are engaged. Well, can you get the microphone? Why don't we talk about that? Why do you think? Let's just throw it out
Like,
there.
my question is like, why don't you know? But you said the actual providers?
These are providers. They're either clinical or non-clinical, and this was an MAT survey, and so we have specifically targeted these providers, and so they were also engaged enough to complete an MAT survey, which, by the way, we had no incentive either.
Yeah.
So, I think the level of awareness is pretty low, even for an engaged population.
Yeah, those numbers kind of high to me to say that you don't know, and then it would lead me to say why you don't know, or either you just didn't feel like filling out the survey. I don't know.
Right. I mean, it could have been, and I do look for kind of those when people just go through don't know. I usually see that more in incentive-based surveys, that people just try to finish this. This is a non-incentive-based survey, so I didn't see that kind of response. But I think it's a really good question, and I'm wondering if anyone else has any thoughts. I think Jonathan might have some thoughts on that.
I think part of it may be, and I'm saying this based on my current experiences, is that especially those folks that have been in addiction medicine and in SUD for years, is either black or white. For instance, and I had this discussion with a manager not long ago, where if you have harm reduction and risk reduction isn't considered progress in some folks' eyes. It's either total
Yeah.
abstinence.
Yeah.
They either are or they aren't.
Right. Right.
Now that's very good. Because I think, like I said, I just do like some of the Gippers sometimes,
Yep.
and patients just talk to me. They say, "Well, I'm doing a lot better than I was. I'm not using as much." And I used to be back in the day when I was kind of black and white, but now I realize that's good. That they're not using as much. So he's right. It could be that if you're just not clean, or you're not, yeah, that could be where that falls in. Oh, or could the other thing, do they have access to the data?
Yeah, I mean, that could be something within that as well. I think that isn't something that overwhelmingly came up within that, but I think sometimes you don't know what you don't know, right? And so I think that's one of the goals of getting people here, and now our role is to go out there and tell people about this and get the data to them, or get the information that they need to know that we have all of these tools in our arsenal, and it's not a one size fits all, but we have tools in our arsenal, and how do we get these tools out to people when they're ready? It's not for everyone, but when they're ready, how do we make sure that they're set up for success? And how do we measure success? Like the two of you were saying, like, there isn't this black and white. It's on a continuum of recovery, right? And then we may go 2 steps, and we may go 2 steps back. But, that is how recovery is, right?
And if it's person-centered,
Yep.
and that's one of the things that, having done this for over 30 years, as the paradigm shifts in the treatment approaches to evidence-based interventions and those kinds of things, that has an impact on person-centered. That means that not all of us have to do the same thing.
Right.
John is John, and his progress is measured by that baseline that he establishes.
Right. And then I think, John, your point goes back to that slide we saw before, and what's your name again? Angie. And what Angie was saying too about empowering clients and patients with those treatment goals and the treatment plans within that too. And that's a part of tailoring for patient-centered, and not having the one-size-fits-all, but knowing different things work for different people, and that people have different motivations as well, which I'm sure can be exhausting for a provider as well. So then we asked acceptability. So again, we're continuing to see a theme here within there. So participants were asked, how acceptable is the use of each of the following treatment techniques for opioid use disorder? So it's buprenorphine, methadone, and naltrexone as well. Is anyone surprised by this data when they look at it? Sorry.
A little bit, yeah. I think there is a contingent of non-medical providers who have jumped on the naltrexone. I know it is a least-effective medication, it's not an opioid, so some people think that it's better,
Right.
even though the clinical evidence doesn't really support that. So, yeah, I just think you should see that because the drug study responders
Easy, Angie. That's not till the reception we get that crazy, all right? Perfect. Okay. Yeah, so there definitely seems to be some favoritism for buprenorphine over methadone and naltrexone with those who, again, this is a sample of 120, so we have to be careful with the generalizability, but I think it's something that is there a level of awareness that we need to make clear within this, and just having more resources, more accessibility for clinical and non-clinical providers. Okay, so this slide looks ugly, but what I'm going to just highlight is asked these providers about their attitudes, because we wanted to know what are their attitudes that they're bringing to the table when they interact with clients, because providers have opinions and feelings just like all of us do. But we asked them a series of questions, and really on a scale from strongly disagree to strongly agree. So I'm just going to go through this high level, but that medications should be integrated. So most agreed with that. Treating patients with opioid use disorder is difficult. Most agreed with that as well. I have concerns regarding misuse of medication. So that was more, then these kind of are more in the central part of the Likert scale within that. The cost of buprenorphine is a barrier for my patients. So not really. My patients are concerned about confidentiality. So again, more in the middle, more kind of a neutral, and then buprenorphine should only be used for a specific period of time. But I think one of the things is my patients with opioid addiction are motivated to discontinue use. And so most actually didn't agree with that, as it kind of goes lower within there. And then I don't want to treat patients with opioid use disorder. So most disagreed. So again, that's good, because those are providers that are engaged in this work as well. And then looking at, I don't believe in this type of treatment. And all of these were picked based on a literature review, really looking at these different attitudes that providers bring to the table. Yep. Yep. Right. Right. Yep. Yes, I didn't think there would be 1.6. I mean, it's, it's low. I mean, it's on a Likert scale, but I thought, and even if you believe in it, there's, social desirability bias, right? People are going to be like, oh, I would never say that, but that people did even say that. And yes, so all of those things did surprise me, like the knowledge, the effectiveness, the some of these attitudes within there. And so that really just tells me, like, there needs to be an awareness and debunking some of the myths and getting rid of the stigma that is often attached even with providers. And I think there are some people that are still in the field that are black and white, right? So, so I think that kind of that harm reduction mentality has not been adopted by everyone who's been in this field either. Well, maybe they believe in other treatments, like more behavioral treatments, rather than, I don't know. I'm totally postulating here. So, what do you think? Do you want to say something in the back? Okay. Great. Yeah. Right. So not all of those that answered this prescribe MAT within there. So only 19% prescribe MAT within that. But they do provide MAT services. So they might provide support services. So the case management that's associated with it as well. And so they're involved within it. They can be what? Yes. I mean, it could be a part of, like, you could be a case manager for Ryan White, and, this is maybe something, against your beliefs within that too. But I think those are questions, like, I think George said it today in the monkeypox presentation, and I don't know who's there, but why after 40 plus years are we still talking about stigma? Like HIV, monkey, mpox, drug use. It is still, stigma is still so present, and even in providers that are engaged, there is definitely stigma and awareness that needs to happen as well. But again, I think providers also have a lot on their plates as well, so kind of adopting new practices, maybe they just don't want to. I don't know. John, I don't know if you have anything to respond to Dan's comments about that, but yeah. 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 Well, that's great. Um, they can feel it. I mean, they know it when someone's engaged versus not engaged, or versus forced to doing it, like we were hypothesizing about as well. Okay, great. I'm gonna I'm a moderator and a speaker. Okay. I think this ends at 3:30. Does it? Okay. Let's keep going. So again, we were talking about those wraparound services and how they're so essential into the access of along the continuum of recovery within that. And so we were just asking about what type of services do you provide on-site versus off-site versus not offering. So most of these services are offered either on-site or off-site. Looking at the mental health, looking at naloxone, also looking at hepatitis services, which is really essential for injecting drug use, and HIV. There's a lot of intersectionality with HIV and STIs, but then also looking at family partner substance use support services. So when someone is in recovery or someone is using, it doesn't just affect that one person, right? So having those services within there. But a lot of are not offering that. So that's the biggest one they're not offering as well. And then also syringe service providers, safe syringe places, not as well. And then inpatient detox, obviously, because you need specific resources for that too. So those are the services. And then these are the other wraparound services as well, the kind of more upstream social determinants of health, which are needed within it. And so surprisingly, lots of childcare here so that people can go and get their treatments as well. I mean, when you're doing something daily, I think that's really necessary. So that's really encouraging to see that. And then looking at legal services, housing, employment, all these are really things. So I think the big numbers to kind of look up here is who's not offering it and whether they have a warm handoff or not. So really just like a diversity of wraparound services within there that they're providing in conjunction to MAT. Okay, so quickly, barriers. So again, how I divided this up was prescribers versus non-prescribers. And so this is kind of the money shot within here, but barriers to providing MAT. So just inadequately trained, patient need is low, and COVID. So again, we did this a year ago, a little less than a year ago, but I don't know if COVID would have come up in this if we did it again, because it was really acute and Delta was really around. So time is always important, understanding that impact of your survey too. And then supports needed to provide MAT, training, money, increased reimbursement as well, then access to CBT, and staff to provide those wraparound services that we saw before too. So, and then for those who prescribe, some of the things that we were talking about before is insufficient time or lack of confidence, low reimbursement. there's also a lot of liability within this, and then there's a lot of documentation as well. And then supports needed to provide MAT. So really, again, looking at that co-location model, so we asked about services being on-site or off-site, so they refer. We know when patients have a warm handoff within the same place, they are more likely to access those services. When you have a more fragmented healthcare system, it's way more difficult to go and access those services. So really having kind of a patient medical home or that patient center that John was talking about is something that the prescribers in this survey really wanted. And then again, trainings, TA, CME, we saw that throughout the data as well, and different data points of like the lack of awareness and the effectiveness as well. Would anyone add anything to these barriers and support from your perspective of what you need that you feel like might be missing? You have everything you need. All right. And so how do you get training and education? So obviously at HealthHIV, that's where we work, and we really want to make sure that we're providing education and resources in a way that's a digestible format for people that will take and participate in these opportunities. So CME, or looking at the hospital or health department, because again, those are trusted sources that they're coming from, and then an accredited medical course too. So kind of having this incentive within it that is time well spent or coming from a trusted resource. So as I said before, I'm gonna just skip over this slide. One of our goals from this survey was really having a data to action approach, is making sure that we were doing community of practices. So that's kind of taking a collective group together that has an overall mission and really addressing this as a unit. So I want to talk through some of that. But what our implication is, we need to increase the confidence of multidisciplinary providers. We need to increase skills on identifying and managing potential medication misuse, but increase referral networks as well. Increase motivational interviewing skills to promote behavior change, and better integrate and coordinate SUD services with pharmacological treatment as well. So again, all points that we talked about, all these implications are supported by the data too. But one of the things the survey, the data to action, is we've hosted 3 community of practice, and these are directly from working with, we have different advisory boards that we work with, but also the survey has informed them as well. And just looking at treatment planning and appropriately identifying medication. So again, that awareness, we saw that there was a gap within the awareness about the effectiveness and use. And so we provided one of that. And then also doing case studies. So that is a really effective method for clinical providers to understand, here's the choices that were made, and being able to ask questions in a really safe place, and understanding opioid receptors and the addiction process within that. But, I want to be mindful and respectful of time, but I did want to open it up based on that. What you all thought of would be helpful for future community of practice. Like, what do you need? What do your colleagues need? Based on this data, what gap did you see that might be helpful for us to start disrupting these epidemics? What's that? Sure. Sure. So there were some questions. So there were a lot of questions that were anyone that provided MAT or MAT associated services answered those questions. But then we had skip patterns within there to talk about just those who prescribe certain prescribing behaviors. And so yes, this one is more aggregated to kind of know the MAT workforce within that. We did look at the differentiations between the two, but given that it was just 19%, it's low. And so that is definitely a limitation within this survey, is that we didn't get as many prescribing providers within that. That is notoriously hard to do because they're usually not at their desk. There is no incentive as well. So if anyone has any thoughts or ideas to increase our response rate with prescribers, I am all ears. But yes, I think that is definitely a limitation within there. And kind of teasing that out when I looked at the data, there weren't huge differences, and I think that's probably because of the 19% within there too. So, great. Anyone have any questions or thoughts before we wrap this up? Good. Yep. Right. Kind of understanding that and understanding all the FDA regulations within there, or just being able, who is the go-to person within there, because this happens and will continue to happen to those younger than 18. Right. Thank you. Yeah, that's a good point too. So maybe addressing something like that in the community of practice, really outlining the things you were saying, and then outlining here are the referral and resources that you can all access to. That's great. Perfect. Well, great. This is my email. It's super easy, Erin at HealthHIV. But I want to thank everyone for coming, but more importantly, for being here overall today and participating and seeing your faces. I know I have definitely missed in-person conferences. My extroverted self is like doing jumping jacks. Some of you introverts, maybe not. But we're glad you're all here and sharing your time, because I know that's your most valuable resource. So thank you for that. And I will see you all later. So take care. Thank you.